going live on YouTube, and today we will talk about a very interesting topic, which is adenoid hypertrophy. In my previous video on MBBS E.N.T, I talked about tonsillitis, where we were talking about palatine tonsils. Now we will talk about nasopharyngeal tonsils, which are also known as adenoids. Now, adenoids are different from palatine tonsils. The main difference is adenoids do not have a fibrous capsule and adenoids do not have crypts. But adenoids do have folds, which are also known as vertical ridges, and adenoids in fact have three types of epithelium: pseudostratified ciliated columnar epithelium, stratified squamous epithelium, and transitional epithelium. Adenoids, like palatine tonsils, play some role in local immunity. However, no data is available which shows that there is significant decrease in immunity following surgical removal of adenoid tissue. However, adenoids should only be removed when the criteria for surgery are met or definite indications of surgery exist. Now, we will talk about where adenoids are located. They are located at the junction of the roof and posterior wall of the nasopharynx. If enlarged, adenoids do undergo increase in size up to the age of 6. This increase in size is physiological, not pathological, and beyond the age of 6, they gradually disappear or undergo atrophy. Adenoids are rarely seen in people above the age of 20 years. So, almost everyone beyond the age of 20 will not have visible adenoids in the nasopharynx. However, if the symptoms are so severe that we cannot wait for physiological atrophy to occur, or if the age of physiological atrophy is already passed and the patient is exhibiting signs and symptoms of adenoid enlargement, it is a good idea to go for treatment. Now, what are the symptoms the patient can have? Patient may have nasal symptoms like nasal obstruction, especially at night. Patient may have difficulty sleeping, nasal discharge, epistaxis or bleeding from nose, sinusitis, which can both be a cause and an effect of adenoid enlargement, and voice change, that is hyponasal voice due to nasal obstruction. There can be some ear symptoms or oral symptoms also due to adenoid enlargement, like recurrent bouts of acute otitis media, failure to recover completely following chronic otitis media, serous otitis media, where one can notice fluctuating hearing loss, as in when the adenoid size increases, there is problems with the eustachian tube resulting in conductive hearing loss, and when the size decreases, then the problems disappear and patient stops having complaints of conductive hearing loss. So there is fluctuating hearing loss due to serous otitis media due to increase and decrease in the size of the adenoids. Also, the nasopharyngeal opening of the eustachian tube can be blocked due to enlarged adenoid tissue, and this blocked sensation can also produce retraction in the tympanic membrane and a blocked sensation in the ear. Moving on, there can be general symptoms due to adenoid enlargement. These can be divided into three headings: aprosexia, pulmonary artery hypertension, and adenoid facies. Aprosexia is just a fancy way of talking about lack of concentration. Now, lack of concentration may be noticed with adenoid enlargement because the patient may have difficulty hearing due to eustachian tube dysfunction, due to retraction of the tympanic membrane, due to serous otitis media. And patient may also have difficulty staying awake or concentrating because of poor quality sleep at night. Pulmonary artery hypertension can be due to nasal obstruction, and pulmonary artery hypertension can lead to right heart failure. Now, adenoid facies is by far one of the most commonly asked questions in MBBS E.N.T exams. Adenoid facies, one must remember, is not due to the very first episode of adenoid enlargement. Adenoid facies is typically due to long-standing enlargement of adenoids or when the adenoid enlargement has been neglected. So the entire facial appearance may undergo change, and patient may have a typical adenoid facies look, which consists of an elongated face with dull expression, an open mouth, prominent and crowded upper teeth, hitched up upper lip, pinched in nose due to disuse atrophy of the Alanizae, and there may even be high arched hard palate due to absence of the molding action of the tongue. So these are the symptoms. Very interesting thing about adenoids is this blood supply. It receives blood, arterial blood, from the third part of maxillary artery, facial artery, ascending pharyngeal artery, and also a branch from the inferior thyroid artery, which is quite interesting. Very difficult to imagine inferior thyroid artery providing arterial blood to adenoids, but it is mentioned in the textbook. So that's interesting. Now, how do we examine adenoids? We can look at adenoids directly through the nose using a rigid endoscope or a flexible nasal endoscope, or we can try the traditional method, which is the posterior rhinoscopy method, for which we need a postnasal space mirror, we need a tongue depressor, we need a headlamp or a head mirror, and a bullseye lamp. So either with the headlamp emanating light that falls on the oral cavity, or with a head mirror that reflects the light from the bullseye lamp, which again falls on the oral cavity. We ask the patient to open the mouth. We have to warm the mirror end of the postnasal space mirror either over the flame of a spirit lamp or in by dipping it in warm water, and we have to check if the postnasal space mirror is too warm or not by touching the metal surface on the back of our wrist. We want it to be just warm enough to prevent fogging, but we don't want it to be too warm so that it results in thermal injury to the patient. So we depress the tongue by holding the tongue depressor in our non-dominant hand, and of course we have to place the tip of the tongue depressor at the junction of anterior two-third and posterior two-third. We should slowly introduce the postnasal space mirror by keeping the mirror surface facing upwards. The light should fall on the mirror surface. We will be able to see the image of the nasopharynx on the mirror surface. If there is enlarged adenoid tissue, we'll be able to notice that. This is the posterior rhino method of examining adenoids. We can also prescribe you soft tissue of nasopharynx, X-ray of soft tissue nasal view with extended neck and open mouth. This also helps in understanding whether the soft tissue shadow of enlarged adenoids is compressing the nasopharyngeal airway. Finally, if the symptoms are not so severe, even breathing exercises or topical decongestant drops or oral antihistamines can suffice. However, if the symptoms are severe, the mainstay of treatment remains surgery, which is adenoidectomy under general anesthesia. Sometimes adenoidectomy is combined with tonsillectomy, and this is called adenotonsillectomy, and sometimes adenoidectomy is combined with ear surgery, which is myringotomy with grommet insertion. In that case, the surgery becomes adenoidectomy with grommet insertion. The grommet insertion is done to treat the serous otitis media, which is often present in patients with adenoid enlargement. But before you perform adenoidectomy, it is very important to note if the patient has submucous cleft palate or not. Of course, if the patient has cleft palate, then that becomes a contraindication for adenoidectomy. But submucous cleft palate is not something which you can easily see. So you have to look for it. You need to know what to look for. If the patient has bifid or bifid uvula, if there is a translucent crease over the soft palate, and if you can palpate a cleft on the soft palate, then the patient has submucous cleft palate. In this patient of submucous cleft palate, if you perform adenoidectomy, it can produce a catastrophic condition called velopharyngeal insufficiency. So submucous cleft palate is an absolute contraindication for adenoidectomy, something that we should never miss out on. Okay, I hope you liked my live video, and if you have any questions, if you noticed any inaccuracies, if I may have misspoken, then please don't hesitate to point out in the comment section. And thank you for watching Must YouTube live video. Take care and bye bye, and please don't forget to be awesome.